So it's really a pleasure to introduce our visiting professor this week. Dr. Prabir Roy-Chaudhury is the Drs. Ronald and Catherine Falk Eminent Professor and co-director of the University of North Carolina Kidney Center, staff nephrologist at the Salisbury VA, and a transplant nephrologist. Dr. Roy-Chaudhury graduated from the Armed Forces Medical College at Pune, India, completed internal medicine and nephrology training at University of Aberdeen, Scotland, and then went ahead and did it again at University of Cincinnati and Beth Israel. Dr. Chaudhury's main research interest is in dialysis vascular access and cardiovascular complications in uremia, which I think we'll hear a little bit more about today. He's made huge contributions, it goes without saying, to the international academic community, supported by NIH, VA, industry funding. He's also the founding ASN co-chair of the Kidney Health Initiative, which is, as we know, a private public partnership between ASN and the US FDA. Maybe in relation to these responsibilities, one of the few people in the room has already knocked out a study section meeting this morning at 6 a.m. And then maybe last I'll mention, of course, he's been active in public policy and administrative aspects of dialysis vascular access, and will continue to do so as now the president-elect of ASN, so president next year. And with that, pleasure to introduce Dr. Roy-Chaudhury.
Great, wonderful, Kate. Thanks so much for that very kind introduction. I just wanted to say it's a pleasure to be here for the science, of course, and it's really tough to follow Bino, but also for the friendships. And I see Jonathan and Raj, and just as I look around, Bessie, Brian Kestenbaum and I were residents together, believe it or not, in Cincinnati. So we go back a very, very long time. And then some new friends, my ANNA friend, just sitting there, and of course I'm terrible with names and I forget your name, but yeah, it is a pleasure to be back. Ashley, who directed me to this place when I was looking around. So with that, I'm going to start off with some disclosures. I will say that in terms of what I'm going to say, the BARD BG disclosure is probably the most relevant one. Bino said that it's the Ides of March, and he used the appropriate starting sentence. I'm going to say that yesterday was World Kidney Day, and so I'm going to continue. And we've always ASN has always said that it should be World Kidney Month. So I just want to show us a few slides that I think are really important for all of us, wearing the hat, as I think all of us should, of a member of the global kidney community. So you've seen this sort of slide. Lots of people have kidney disease. It affects a lot of people in this country. It costs a lot of money in this country. And if you put all of that together, I would say that, the morbidity and the mortality and the economic cost is impossible for an average citizen to bear. And so governments have to come in. And so if you're lucky to live in the industrialized world, it's a huge drain on the exchequer. And we get really poor results, as you've heard, in terms of survival on dialysis. But I would say that everyone on dialysis in this country, they're all the lucky ones, because for most parts of the world, and I would say that 6 million of the 8 billion, that should be a B, 6 billion of the 8 billion people on this planet live in countries where access to dialysis is basically limited by cost. And so one could say that, wow, it's great. We dialyzed over 3 million people in 2020, but the real number, I think, has to be the 8 million people who died because of a lack of access to conventional standard dialytic therapy. And that number is almost certainly a gross underestimate. And that allows me to go back, I would say, over 50 years to what Martin Luther King said. And he said in 1966, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And I would argue that over the 50 years plus since 1966, that this inequity, particularly in the opportunity to get kidney replacement therapy, has increased, because most parts of the world now have it, but also in most parts of the world, more people don't have it. And earlier there was no kidney a kidney therapy at all, but now there is. I think it's just as true in this country as it is worldwide, albeit in different ways. And I think one of the challenges that I would like to put to all of you on World Kidney Day is to, and this is a center of innovation, as we've heard, Bino, you've done great work, but how do we address this issue about making sure that innovation and all the innovations that we've heard about in the previous talk actually end up reducing rather than enhancing disparities in kidney care? Because often the new things, and we had a conversation yesterday of Kate putting somebody onto Tarpeo at $90,000, right? So that's I guess that's innovation, but how does it impact everybody? And my next slide has an origin, I would say, by my apologies, Jonathan, right here in Seattle, and I don't know where this is, probably an old slide, but the bottom line is, if we're talking about innovation, how do we have a cell phone moment in kidney care? And by a cell phone moment, I mean, how do we create, or how do we have this quantum jump in technology, right? That makes the efficacy, and the efficiency of whatever we're using for kidney preservation or regeneration amazingly different and top class. But at the same time, how do you leverage that, as cell phones have, with a decrease in cost? Because it's that cell phone moment really that's going to allow us to have access either to preventive or regenerative or therapeutic kidney care across the world. So with that, and I do think it's important for places like us. And I think, you know, this group has always had a global outlook. I think that there is an opportunity for nephrology in this country to be very global in its outlook. And I think that's a huge plus for the kidney community in this country. So with that, let's go back to what you really got me here to talk about, which is about dialysis vascular access. And I'm going to divide this talk into four main parts. I'm initially going to speak a little bit about the pathology and pathogenesis of dialysis vascular access dysfunction. I'm then going to use that information to tell you about some innovative patient-centered therapies for dialysis vascular access dysfunction. But then in the second part of the presentation, I'm going to go off in a different direction. And I'm just going to try and make the point that innovation isn't just about discovery, it's about process, it's about regulation, it's about reimbursement. And all of these things are important if we ultimately want to get new therapies to the patients who, I would say, in the kidney world are desperately waiting for these therapies. And then finally, I'll end with some messages for the future. I want to start off, however, with a very clear message for the present. And I'm going to say that this is a challenge to all of us, a call to action for all of us in the area of vascular access. And so if you look at the picture on the left, that's the picture that was in the 1966, actually the same year Martin Luther King used the quote that I shared with you. A picture in the New England Journal of Medicine in 1966 showing one of the first arteriovenous fistula. I will say that there were 4 authors on this paper. Brescia, who was anyone? Nephrologist. Simino, who was a nephrologist. Hurwitz, who was a nephrologist. So Ken Appel was the surgeon, actually. So just remember, the first paper on AV fistula, we were talking yesterday about nephrology sort of gaining back things. This is a nephrology paper that came out on arteriovenous fistula. But 1966, and in 1978, so about 12 years later, it was well known that arteriovenous fistulae fail because you actually have a perianastomotic stenosis. But from there, if you fast forward almost another 40 years, the panel on the right shows you the data from the hemodialysis fistula maturation study. And very clearly, in the year 2022, if you place 100 fistulae in this country, only 44 will actually be able to support good dialysis without any interventions. About 22% will be able to support dialysis after they have an angioplasty or a repeat surgical procedure, 34% will be abandoned totally, right? And this is around something that we knew occurred way back in 1978. And so the call of action that I'm going to put to all of you is that I would argue that a lack of true change has resulted in the poor value that we provide for vascular access care, in that we spend a huge amount of money. It's been estimated to be perhaps as much as $5 billion per year. And for that, we actually get a 50 to 60% patency, unassisted patency at 1 year overall, let's say for fistulae and grafts. And that is without any mention at all about quality of life or about equity in vascular access. So coming back again to inequity, I would say that in this country, we know that Black and Hispanic patients have lower incident AVF rates, and this occurs regardless of the insurance of that individual. And we also know that Black patients in particular do worse at every step in fistula care, from initial placement to maturation to long-term patency. So the question, of course, is how do we change this? And what my next slide shows, it tells you about some pillars of change. And these pillars of change, I would argue, are true for vascular access, they're true for dialysis, they're true for kidney care, they're probably true for science and for life in general. And the pillars of equity or change, pillars of change really, one of which is equity, really go all the way from biology to different types of innovation, down to regulation and reimbursement, to public policy, to investment, to interest, and then to equity. And what I'm going to do over the next 30 minutes or so is really touch upon most of these different pillars in the specific context of vascular access. So I'm going to start off by showing this slide to you, which should be familiar to most of you. I describe it as a radiological presentation of dialysis vascular access dysfunction. So if you look at the left panel, you see an angiogram of a fistula with a tight perianastomotic stenosis here. This is the lesion that results in fistula non-maturation. This is the lesion that is responsible for the fact that if you have 100 people start dialysis with tunnel dialysis catheters, and remember 80% of all patients starting dialysis start with a catheter, but if you take a group of patients who started dialysis with a catheter, at the end of 6 months, about 50% of them or less than 50% have a fistula that works, and that's partly because of process of care issues and partly because of the slow maturation. And actually a very significant percentage, as you know, have died. And I would say that there is some impact of vascular access or bad vascular access on that. If you look at the right panel, you see a very tight stenosis at the graft vein anastomosis. This is the lesion that results in graft thrombosis. So now if we do a deep dive into these lesions, if you take tissue from both of these areas and look at them under a microscope, and this is what we started doing now a couple of decades ago, you get what I have described as the classical histological presentation of dialysis vascular access dysfunction. And this is really an aggressive venous neointimal hyperplasia that is made up of smooth muscle cells and myofibroblasts and fibroblasts that have migrated in from the media and perhaps also from the adventitia in response to hemodynamic stress and surgical injury. Now, there are two additional points that are very important in this, what I would describe now as the more traditional sort of hypothesis or description. So one is that all of these changes are likely exaggerated by the inflammation, the oxidative stress, and the endothelial dysfunction that characterizes uremia. So that's a very important point, I think. The second very, very important point also is that it's important to remember that the final amount of stenosis is always a combination of the amount of neointimal hyperplasia together with the amount of inward or negative remodeling or a lack of positive or outward remodeling. And I will say, and I'll show you a little bit of this data, that it's now thought that this inward remodeling or lack of positive remodeling, and we'll talk about some of the reasons for this, is at least as important, if not more important, than neointimal hyperplasia that happens after you create the fistula. If you were to put all of this together, there are three areas that I'm going to speak a little bit more about over the next few slides. I'm going to talk a bit more about hemodynamics, about uremic vascular biology, and not shown on this slide, I'm also going to talk a little bit more about process of care. But let's start off with hemodynamics. So I love the panel on the left. It shows you the huge, each of those little figures is the angle or the way that a fistula was created in a single center. This is data actually from Imperial College in the UK. So we create fistulae in a whole host of different ways, depending on your vein and artery. But if you put all of this information together, the one thing that comes out is that you probably need to have an angle that is larger rather than more acute in order to have overall good function. So I just want you to keep that in your mind. And my next slide speaks a little bit more about things like angle and about hemodynamics. So this is an area that we've been really interested in. And the bottom line from a subset of a large study that I'll speak to you a little bit more about, the Hemodialysis Fistula Maturation Consortium, really is that if you have a low wall shear stress, which correlates with non-laminar flow, that you're probably going to have more stenosis and less positive remodeling. While on the other hand, if you have more oscillatory shear, which again correlates with non-laminar flow. So turbulence, non-laminar flow tends to result in bad things when you're talking about a fistula. And obviously that opens up a whole set of potential possibilities. Can you adjust the angle? Can you adjust the configuration? Can you use an external scaffold? And again, I think there have been some advances in that area, but clearly a huge opportunity. So that's all I'm going to say about hemodynamics. It's important. There's an opportunity for intervention. What about vascular biology? So I spoke about neointimal hyperplasia, and I will say that there is data now, and I'm not showing that, is that if you look at veins in somebody with chronic kidney disease, even before you create a fistula, you're going to get neointimal hyperplasia. And that doesn't actually seem to correlate with how your vascular access actually does. That's pre-existing neointimal hyperplasia. There is some nice data from actually a very neat model, and I'm going to put it out there. It's a two-stage brachial transposition model that Dr. Vasquez Padron at Miami has used a lot. And what he does is when you create the initial first stage of the base of the basilic transposition, he takes a little bit of sample, and this is basically describes to you the impact of uremia, let's say, without hemodynamics. And then he takes the second stage. When he creates the second stage, he takes another sample, which is the impact of both uremia and blood flow, because now the vein has been exposed to blood flow. And what he's been able to show is that it's actually medial fibrosis that may actually play an important role or have an association with fistula failure. And that makes sense if you think about medial fibrosis potentially preventing the outward dilatation of the fistula. And he's also been able to show that those samples that have both medial fibrosis and neointimal hyperplasia actually tend to have the most non-maturation. So I think that's an interesting point, again, for us to remember in terms of the biology of fistula non-maturation. And then another point that I want to make about biology, and I think, Jonathan, and you're on this paper, obviously, as well, is that one of the other findings from the hemodialysis fistula maturation cohort, which I'm actually going to describe on the next slide, which is probably bad, is that, but it was a large study of 600 patients, and we looked to see how fistulae actually matured. But we did a lot of ultrasounds, and what we found was that, if you looked at a group of fistulae at 2 weeks, we found that 28% of them actually had a stenosis. At 6 weeks, it was 30%. But the interesting thing is that these weren't the same fistulae, right? So between 2 and 6 weeks, 36 fistulae with stenosis ended up not having a stenosis, but another 16% from the group with no stenosis ended up having a stenosis. Again, I put this out there to tweak your interest. Stenosis can be dynamic, and it means that we shouldn't aggressively perhaps go in and dilate everything at 2 weeks or potentially at 3 3 to 4 weeks. So that's about biology. A little bit more about the Hemodialysis Fistula Maturation Consortium, which I've already mentioned. In a way, I've shown you data from large prospective study, 7 centers, 600 participants. We were a site in Cincinnati. Jonathan was a site, I forget, was it at Maine? It was after you came. It was after you came to UW. And basically what we did was that we followed up 602 patients with an AV fistula. They all had a single stage fistula. We collected lots and lots of data, right? We collected data, clinical data, demographic data. We did ultrasounds before, we did ultrasounds after, and we collected venous tissue, and that's the data I've shown you already at the time of surgery. And then we followed the fistulae till abandonment. One of the results that I feel is an important result, although we probably knew about it before we did this large study, is that early blood flow plays a very important role in determining final fistula maturation. So if you divided our fistulae into those 3 groups that I spoke about, the ones that failed, the ones that worked but needed angioplasty, and the ones that worked without any angioplasty, you find that the unassisted group started off with a high flow at day 1, and the flow kept increasing. The failure group started off with a low flow, it went up a little bit and then came down. So flow is really, really important in determining whether a fistula is going to work or not. But what I really want to focus on is a process of care effect, or what we've called an independent clinical center effect. Because over and above the impact of flow on fistula success or failure, we found that even after you corrected for case mix and location of stenosis, arterial diameter, there seemed to be an independent clinical center effect. So what do I mean by that? What I mean by that is that if you look at data where each of the centers is plotted across with 6-week blood flow on the x-axis and the probability of maturation on the y, if you're in the red center and if you have a blood flow of 800 at 6 weeks, the HFM data said that you have a 28% chance of maturation. But if you were in the brown center with the same blood flow, you actually had this significantly different chance of maturation, which suggests that there is something beyond biology or clinical parameters, and which is likely to be process of care. Now, I think that this is an area that we still have to peel back the different layers. But just to give you an example, when we looked at different process of care factors, and this was a paper by Mike Allon, one of the things we found was that in our 7 centers, 3 of the centers actually used post-operative ultrasound routinely, while the other 4 didn't. And conventional thinking would be that the centers that use post-operative ultrasound routinely, let's say at 2 weeks, would actually do better because we're using a new test and it should be good. But in fact, it was the other way around. The centers that use ultrasound actually tended to have a delay in when they were able to use their fistula. And maybe we were finding things that we were placing too much credence on. I don't know the reasons, but to me, it's always that this is a prime example that sometimes in medicine, less is actually more. So that's what I'm going to talk about, pathology and pathogenesis. But what I am going to do to take us to the next step, which is about new therapies and innovation, is I'm going to try and put all of this together. And so the way that we currently think about vascular access dysfunction, including fistula maturation, is that initially you have these 2 interacting and upstream pathogenetic pathways, hemodynamics and uremic vascular biology. And the 2 of them together then result in another 2 also interacting, but downstream pathological pathways, inward remodeling, and the neointimal hyperplasia that I've spoken about. And the reason that this sort of construct, I think, is so important as we think about the next step is that I think if you want to develop novel therapies for vascular access as a whole, I think it's really important that your therapy targets one or more of these different upstream or downstream pathways. I think it's also important, and my thinking on this has been influenced so much by my time in the Kidney Health Initiative, is that it's important that these therapies are patient-centered. And I just want to speak a little bit about that, giving an example from hemodialysis. So this is some data which shows you what patients and their physicians think about what is really important if you're on hemodialysis. The bottom line is that if you're a patient, you're concerned about your ability to travel, about dialysis free time, and about not being washed out after dialysis or the recovery time. But if you're a physician who's looking after these same patients, that's us as nephrologists, we're focused on survival and hospitalization, and we obsess about blood pressure, right? It's too high, it's too low, it's just right. We're nephrologists. But the bottom line is very different from what our patients are concerned about. And I think that's really important to think about when you're wanting to develop new therapies. What about vascular access? Well, the data is much less, but the trends are similar. There's a small study which suggests that for patients who have vascular access and were asked about it, that physical complications such as pain and cannulation and disruption to routine were more important as compared to what we would consider really important for vascular access, which is infection. So again, I think it's really important to think about this as you go down the pathway of new therapies. But having said that, I think it is an exciting time for vascular access because there are a number of therapies, I would say, in the clinic or in clinical trials that are trying to target biological pathways in a patient-centered manner, and they go all the way from creation of the access to maturation to maintenance. And I'm just going to share with you some examples, and I'm going to start off with creation. And I just want to ask a question: do you all create endo-AVFs here at UW? So you have, yes. So this may be a repetition. But there's been a lot of interest on creating a fistula using an endovascular approach. There are two companies out there with two devices. So there's BD with the wavelength system, there's Medtronic with the ellipsis system. And the idea over here is that, or the biological rationale, I would say, is that if you can create a fistula without handling of the vein and the surgical insults and the torsion of the vein, then maybe you're not going to have that perianastomotic stenosis. And the way that this takes place, and I'm going to show you a video over here, is that what you do is you identify in the upper extremity where an artery and a vein are really close to each other. You put in your sheets. This can be done by an interventional nephrologist. And once you put your sheets in, you put these special catheters in, and these catheters actually have a magnet, which is shown over here. And when you activate the magnet, the artery and the vein comes together, and then the system delivers a blast of radio frequency energy. And this creates a hole between the artery and the vein, and you get this nice flow after you remove the catheters from the artery into the vein. Now, a lot of this, the blood flow goes into the deep veins, and so you can coil the deep veins to preferentially allow the blood flow to go through the superficial veins, and you put your needles into a fistula. So I think, I always think that that's just very neat to show this video. There's another device, the Medtronic ellipsis device. I'm not going to show the video for that. But what I will say, and this is a play on words, the first time I put my finger on one of these fistulae, it was a thrill to feel a thrill without a scar. I mean, it really is. So, and this is an example of what it looks like. So this is where the connection has been made, no scar over here, and you actually see something going up both the basilic and the cephalic venous systems. And you can actually put a needle over here and another one over here. And that's actually one way to use these endo-AVFs. What about clinical outcome? High procedural success rate, but remember, first-in-man studies, I say, are always 20 points better than what the reality is. We don't have RCT data because it's really difficult to create a surgical fistula in exactly the same position. There is a post-marketing study going on. We'll speak a little bit more about that perhaps in the questions. I'll remind you to ask me about that. But I have been a fan of these endo-AVFs. And I am a fan of the endo-AVFs because I think that they do have a patient-centered component, right? I don't know whether we're going to be able to use them in 20% of people or 80% of people who need a fistula. But the absence of surgery for many patients is actually good. And do remember that we're quite unique in that we've got surgery and we've got radiology and everything in large centers. But the fact that an interventionalist can create this means that there will be more access for patients to different types of providers, particularly in rural and other areas. So I think that that is a big plus for this intervention. What about some other interventions? A lot of interest in bioengineered grafts. Is a company called Humacyte, which creates a scaffold in the form of a vessel. It then takes mesenchymal cells from donors and it seeds these scaffolds with these mesenchymal cells. The cells then do what cells always do when you put them into a bioreactor and on a scaffold, they proliferate, they migrate, they create extracellular matrix proteins, and you get something that looks like this. You then get rid of all of the cells because you don't want an anti-HLA reaction. And at this point, you're left with something that really looks like a vessel and feels like a vessel. These vessels have been used as bioengineered grafts for vascular access. Some of them have been explanted, and to me, it's really important that even in the explanted tissue, there was a lot of cellular integration. So you could say that this is a living, breathing vessel. There is a large phase 3 study that has been completed, and this slide is wrong. This study, the full results are not out, but I'm not sure that it actually showed a huge benefit as compared to PTFE graft. So I think this is an area that we need to follow, but it's not just, I don't think you can say, wow, this sounds really good and really nice and lots of cells and it works better as well. That may not be true. Or it might be in certain circumstances. Another intervention, which I think is quite neat, it's an external support that's placed around the venous limb of a fistula. And the idea over here is that you're going to get just the right angle to get nice flow. This device is actually in clinical trials. I spoke yesterday about pulsatility and vibration being important. And, I just wonder whether the scaffold actually prevents the pulsatility and vibration that you get when you create an arteriovenous fistula. I'm going to jump over this in the interest of time. But I am going to speak a little bit about drug-coated balloons. So these are now out there. And the 4 patients with venous segment stenosis in the setting of a fistula or a graft. And basically what happens is that when you do an angioplasty, when you have a fistula stenosis, it's good because you open up the vessel. It's bad because you cause more vascular injury. And so what you can do is to really blow up a drug-coated balloon, which is usually coated with paclitaxel, which is highly lipophilic at the site of your initial angioplasty. And then the paclitaxel prevents your restenosis. Initial results in a study that I was a part of did not show a difference. But since then, there's been a study by Medtronic, which shows that there was a significant 20% difference in post-intervention primary patency at 6 months, and that this difference continued out at 3 years, albeit in a smaller percentage. Now, I am going to raise the point because I think this is an important issue, and we'll speak a little bit more about this, is that if you have an outpatient freestanding vascular access center, you do not have access to these drug-coated balloons because it's too expensive. And so again, at times I wrestle with the issue, what are the ethical aspects of sending people to these access centers when maybe some of them, but we don't know who, would be better served by going to a place where you do have access to these other newer interventions. One of the things that I'm going to speak very quickly about is some of the things that we're doing in new innovations. And I shared a little bit about this yesterday. We're very interested in biodegradable stents that can be turned on and off for arteriovenous fistulae. We're very interested in our own version of bioengineered vessels, where the idea is to put in a scaffold that has just the right polymers and just the right sort of angles between the different fibers of the polymer to attract in just the right combination of cells, including endothelial cells shown over here. Because as I said yesterday, the holy grail of vascular access is if you can get a layer of nice, very functional endothelial cells that do all the right things, you are absolutely golden. And this is with Dr. Wang, who's at Cornell. And then we have another project where our grant was unsuccessful, but we're going in again, working with Alyssa Panich at Georgia Tech and Emory. She has an endothelial protectant, and we know that there's a lot of damage to the endothelial cell when you initially create a fistula. And the idea is to use this endothelial protectant to really tweak that initial sort of biological system in just the right direction. So lots of new therapies, and that's exciting. But the real benefit, I think, of these new therapies is that in the future, these novel technologies could allow us this KDIGO and KDOKI, and I think everyone's dream of being able to get the right access into the right patient at the right time and being able to give patients with vascular access dysfunction the right treatment. So what exactly do I mean by that, and how can these new therapies help us with that? So let's suppose that we have a 50-year-old who's already got a catheter, average veins, diabetes, hypertension, has had a stroke. We would normally create a fistula in this patient if the vein and the artery were of adequate size, but we would recognize that everything suggests that this patient, particularly if he has smaller veins and a smaller artery, that the fistula might take 3 months, 4 months, 6 months to mature, and this patient would have a catheter because of our imperfect process of care while the fistula matures. But in the future, if that vascular external structure device that I showed you about is actually shown to work and the initial results are actually quite good, then maybe we could offer this patient a fistula plus approach, which would be a fistula with the vascular device, which would reduce the duration of catheter contact time. And then let's suppose we had an 80-year-old who, no veins, multiple comorbidities, probably going to go to a nursing home, limited life expectancy. Well, maybe a catheter is absolutely the right therapy for this person. But catheters have terrible problems with thrombosis and with infection and central stenosis. But what if you had a catheter, and this is something we're working on, others are working on as well. Our solution would be a catheter that releases nitric oxide that prevents infection and thrombosis and central stenosis. That would be the therapy for the future for this patient. But I would also argue that this could just be the beginning, because just as people are different, so too are their vascular access stenoses. So some stenoses are due to neointimal hyperplasia. Other stenoses are due to a lack of remodeling. Other stenosis are due to an actual active constriction. And so in the future, my dream would be to envisage a structure where we would be able to stratify both our patients and their stenotic lesions using things like IVUS or OCT or direct sampling of the cells, which can now actually be done. And at that point in time, we would be more like oncology or like the KPMP, where we would be able to say that lesion A needs drug-eluting balloon Z, but lesion B needs drug-eluting stent Y. And most importantly, we'd be able to say, and I think this is really a very important point, we'd be able to say that lesion C has such a bad biology and such bad hemodynamics that we shouldn't go in and do 5 angioplasties as we normally do at a cost of $30,000. And at the end of it, everybody gains. I'm wearing my cynical hat here. Everybody gains except for the patient who has to come in 5 times and get rides and undergo these procedures. But we need to say, this isn't going to work. You need a new access, or you need a new therapy, or you have to get a transplant. And we'd also be able to say in another set of patients that this lesion is so good in its responsiveness that all you need to use is an $80 angiodynamic plain old balloon angioplasty, and you'll be set for 2 years. Because some people, you do an angioplasty, they're good for 2 years, and others are coming back every 3 months. And I think that this concept is really important for vascular access. It's really important for patients because vascular access is important for them, and it would allow us to obviously risk stratify, use novel therapies in the patients who would benefit the most from them, and thereby reduce both resource utilization and cost. So now I'm going to switch gears again and just emphasize that it's not just about discovery, innovation, and about biology, because you can have the best idea, the best biology, and the best device. But if you don't have a regulatory and reimbursement pathway, you're never going to get your exciting, sexy, nice new therapy into the patients who need them. And that's why regulatory projects, such as a project that the Kidney Health Initiative, which is a public-private partnership, as Kate mentioned, between the ASN and the FDA, the project that KHI did on clinical trial endpoints for vascular access, that's why it's so important, because now we have a set of 4 papers, including one which is a perspective from the FDA about endpoints, clinical trial endpoints for vascular access. And we need lots more interventions and lots more documentation like this, because it's these sorts of projects which are far away from the biology that I spoke about earlier that can actually serve as a catalyst to enhance innovation in this case, in the vascular access field. We feel that these papers can make it more attractive for industry and academia to come into this field. And we feel that such papers can generate more investment in this area. So the 3 I's, if you will, of product development: interest, investment, and obviously innovation. So with that, I'm going to end with not just one message. I'm not going to let you guys get off so quickly, but I think it's 4 messages for the future, right? The first message is about involving patients in innovation. And I was very influenced by Celeste Lee, who made this video. She was a founding member of the Kidney Health Initiative Board of Directors, and she was persistent and persistent in saying that the KHI needs to have a patient and family partnership. And she got her way, and I think it's the best thing that KHI ever did, because everything that the Kidney Health Initiative now does starts off with having a patient perspective. But what she also did is that in order to get patients to attend a conference that the FDA was having in Baltimore, and this must be now 8 years ago, she created a video. And I think more than anything else, this video tells you about why it's so important to have patients involved in innovation. Oh my goodness, I didn't, is there an auxiliary cable for this? I should have remembered that. It is a cable, oh dear. It's one of the cables which plugs into my voice thing. Oh, terrible. That's okay. Listen, I'm going to, yeah, that's it. Okay, let's be innovative. Go 1 second.
Both chemo and PD. I had a transplant for 10 years, and as you can imagine, too many pills, shots, and accesses to mention. As kidney patients, you and I both know that a few things in life are not optional. Strength, courage, persistence, and determination. No matter what life throws at us, we try to stay balanced, maintain our routine, and remain positive. But let's face it, we are often in a holding pattern. Kidney disease treatments have not changed much over the years. The options for patients like us have largely remained the same for many years. You want to help change that? We need you. Each day we're asked to share our lives with our treatment. But now let's share our voice, ideas, opinions from patients like us. They matter. Few people are realizing our voices matter too. Here's what I found out. The Food and Drug Administration, often known as the FDA, is looking for patients living with kidney disease, like you and me, to provide input on how potential treatments of the future could look. Picture a big table. Around it are dialysis caregivers, researchers, doctors, nurses, and companies providing new products and treatments. They want us and our families to sit beside them and have a seat at this table. We'll work together to bring potential new treatment options, safe and effective ones, and ones that patients like you and me want and need. Imagine the future of your treatment. What does it look like? How does it improve your day-to-day life? This future doesn't have to remain just a dream. Join me and other patients to contribute our thoughts and make our ideas a possible reality. This is my invitation to you. Lend your voice and work with the people who can help make it happen. With one shared goal, living better with kidney disease.
So Celeste passed away about 5 years ago now, and she passed away because she stopped dialysis because her sternum, after 25 years of dialysis, was literally collapsing and was compressing her heart. But again, I think that what she did and what she believed in should be a charge to all of us to address the issues that are important to patients. So I think that's definitely message number one. Message number two, and I think this is also very important, is that technology can completely change existing clinical paradigms. So in the vascular access world, we always speak about fistula first, and we speak about fistula first and catheter last. But just think for a moment that if you had a catheter that never got infected, never resulted in a thrombosis, never caused central stenosis, and was pretty much under the skin and allowed patients to have a shower, then suddenly you go completely from fistula first to catheter first and last. So technology, together with the implementation of that technology, can completely change clinical paradigms. Message number three, I didn't touch too much on this, but it's really important. Many of the problems in vascular access are due to process of care issues. So I spoke a lot about new technologies for trying to get fistulae to mature, but you could argue that we could solve our biggest problem, which is that 80 out of 100 patients starting dialysis start with a tunnel dialysis catheter if we could get a functional fistula in everybody when they start dialysis. You could also argue, even though it seems so far away, that there isn't a lot of rocket science in this. We need to have early referral. We need to have vein preservation programs. When your eGFR goes down, we need to have a group of surgeons who are committed and dedicated to vascular access, and now interventionalists as well. We need to have our patients not wait for a long time to get a slot in the operating room. We need to follow up these fistulae at 4 to 6 weeks. We need to intervene as required. And then when the patient is ready to start dialysis, because all of this needs to occur in the CKD phase, we need to emphasize that we use expert cannulators in order to cannulate these fistulae. Now, it's easy to say this, but there are incredible process of care issues and barriers for all of these. But I would say that each of those barriers is actually an opportunity for local process of care innovation. So I think process of care is really, really important. And then my fourth message is about how do we put all the stuff that I've spoken about together. And I would argue that we actually have a pretty good handle on the pillars of change for vascular access. And we've actually made progress in many of these fields. But vascular access continues to be a huge clinical problem. And I would submit to all of you that this is because our implementation of what we know we can do is poor. And one of the reasons for this is that vascular access care is totally fragmented because nobody still, I would say, truly owns it, right? We have different types of surgeons. We have nephrologists. We have the dialysis units. We have the CKD clinics for the pre-patients. We have the interventional radiologists. We have vascular access centers. And in addition to this fragmentation, no one has really approached this problem in a truly holistic manner, right? And so what we've started to do at ASN is an initiative, and I hope that ultimately many of you in this room will be involved in this, And the initiative is called Transforming Dialysis Access Together. It is currently chaired by Dr. Vandana Nair, who is an interventional nephrologist at Emory University. And there, from a 30,000-foot level, there are two main goals. Number one, we want to create a platform or a meeting place for the entire dialysis access community. And when I say the entire community, it's patients and nurses and technicians and coordinators and surgeons of every ilk and facility managers and interventional nephrologists, but also payers and regulators and large pharma and innovators and the CDC and researchers. And when we get them all together, and we've actually moved quite a bit ahead in getting these different groups together, we want to use their combined expertise to address dialysis access in a very holistic and cross-cutting manner, going all the way from education and awareness to training, from policy to payment, from equity to advocacy, from innovation to data generation and entrepreneurship. Because just having, as I've emphasized, just having a new idea, just having a new therapy, just having a new process of care without regulation and reimbursement and policy and payment and equity, it doesn't actually work in the right way. I want to emphasize that this is a bottom-up initiative. It's a big tent initiative. We want to get people together. ASN in this instance wants to serve as a convener. We want to change dialysis access together. And our dream over here is that we want to develop a patient-centered ecosystem for discovery and process of care innovation in vascular access that goes all the way from biology to technology to patient care, that goes all the way from initial ideation and investment to the identification of druggable and deviceable targets, to clinical trial infrastructure, surrogate endpoints, and regulation and reimbursement. And we want to surround this innovation ecosystem with equal measures of both equity and access to care. And with that, I'm going to skip my last video. I want to thank a lot of people. Research is always a team science. I cannot match Bino when he said, what did he say? What niches? What is it? Growth niches. Yes, I cannot match that, but I do want to thank many people at ASN and KHI, particularly Melissa West, who I think was very influential in some of the ideas that I've shared with you. I'd like to thank the people in my lab and adjoining labs at UNC. We have lots of collaborations with people at UNC and outside of UNC, and I'm very grateful to my sources of funding. But most of all, thank you to all of you for your attention. I've really enjoyed my visit, and thank you again so much. Yes.
Without a lot of problems. My question is about our vision for portable dialysis. Some people have to wear dialysis machine. So it's like a very compact machine. The question is, what's your vision for the best access for people who have a portable unit on their back or turn catheters? Can they still stick those catheters? Or do we need another generation of access which would allow them to not have infection, take a shower, and have
Yeah, so, you've got Jonathan sitting here, so I'm not going to say too much. What I will say, and I'd love Jonathan to come in as well, obviously, or others here, is that I think that vascular access is absolutely critical to the new generation of continuous devices. And my sense is that the efficacy of clearance that we're going to be able to achieve is going to go up many-fold. In our group, we're very interested in things like graphene oxide membranes, which have just a totally different new level of efficacy. So I think that it's going to be So I think that we're going to have to do things, number one, 24 hours. We're going to be very effective, I think. And I think that the blood flows that we're going to have to deal with are going to be much, much slower. And so I don't have an answer for the true access of the future, but I think that it's going to be smaller. It's going to be ideally inside the body. It's going to be quite compact. It's not going to have the really high flows that we are used to, which I think actually in our patient population, I didn't touch upon this, but this whole issue about heart failure and hyperdynamic circulation becomes important. I think that computational fluid dynamics to prevent clotting within your device is going to be very important. I would say, so I'm not answering your question. I think the access of the future needs to be totally different if we're going to be able to leverage the full power of the future, really small, portable. My vision would be something like a cell phone or implantable devices. But Jonathan or others.
So, we've got a lot about this in terms of
I would maybe challenge you. I mean, could the catheter, you've said it has to be a catheter, but when does a catheter not become a catheter? So a little connection that maybe it just juts out of the skin, or maybe it doesn't. And then another connection, to me, the stuff hanging out, I just don't think that that's the way to go. Yeah. Yes. Yeah, I said yesterday, I'm just going to put out a plug for cannulation. Cannulation is where the $40 billion dialysis industry, interacts with the patient 6 times a week. Cannulation is also the area where there really hasn't been any real innovation. The needles have stayed exactly the same, even though in many other parts of the world there are plastic cannulae, but nothing has changed over the last 25 years. It's not just innovation, it's also about cost and commitment and payment. And I think, and I'm going to be a bit more cynical here, it's we need to give patients bigger voice, because they're the people who are affected by cannulation. Yes. Nisha, yes. It's good to see you. Yeah, no. Yeah, so that's a good question, and I think there are a couple of answers. One answer is that a lot of the biology is quite different, and a lot of the anatomy is quite different. We're dealing with larger vessels. We're dealing with very high blood flows in general, which can cause problems. But the problem of thrombosis, for example, let's say that has mainly come out from the coronaries or the peripherals is maybe not thrombosis because of sluggish flow is maybe not that important, but thrombosis due to stenosis resulting in a superadded thrombosis is perhaps more important. So that's one bucket of reasons. The second bucket is, and again, Jonathan was a part of these studies. I was not the initial dialysis access consortium study. It actually showed that if you used basically clopidogrel, that in patients with a new fistula, you actually reduced the incidence of thrombosis from 19% down to 12%, right? But this finding never really got a lot of traction because that same study also showed that regardless of the use of Plavix or not, there was no difference in the ultimate successful use of the fistula, right? I would argue that there could still, I'd be interested in others' thoughts. So we've never really sort of unwrapped that completely. I will say that we're much more aggressive in terms of interventions now as compared to when the DAC study was done. So maybe if we did it now, because we're more aggressive, we wouldn't have that finding. But that's all the data that I can share. At the present time, I would have to say that there is no evidence at all that using dual antiplatelet agents in the setting of vascular access is of benefit. And we're all aware, obviously, of the increased risk of bleeding in our patients. Yes, Bessie. Bessie? Yeah, no. No, sorry. Yeah. Yeah, no, I can speak about that. So, so again, I have sort of mixed views, huge opportunities here. So if you just look at the angle, let me see, I have to, oh, then I lose my thing. All right. Oh, no, that's fine. Sorry. So, so if you look at flow purely from a hemodynamic perspective, the best angle, and this is in keeping with that initial study I showed you, which actually showed that a small angle is not so good, but the best angle is likely to be 120 degrees, right? Because then you have the artery and you have a nice smooth curve that goes into the vein. The problem at a clinical level is, and that came out also in that first picture. So again, thank you for this question, is that patients have arteries and veins that are suitable for fistula creation in a whole host of different configurations. And on top of that, I think surgeons have their different styles of creating fistulae. I think it is really important that we pay more attention to the angle, understanding that sometimes it can be quite difficult because of venous and arterial anatomy. But I will also venture to say, and this is from our initial PIC studies, is that the amount of non-laminar flow is so much that you're always going to get, almost regardless of the angle, some degree of non-laminar flow. And so I really do believe that if you're looking for a final solution just to fistulae as we know it today, that it needs to be a combination of adjusting the hemodynamics, but also applying a biological therapy that addresses some of the issues around uremia and oxidative stress and endothelial dysfunction and some of the downstream pathways that come about as a result of the non-laminar flow. I would be skeptical that based on our studies that just fixing the angle would be the solution. Bessie, yes, sorry, there you, I knew you were in that direction. Right. So the advantage of an upper arm brachiocephalic is that it tends to mature more quickly, and therefore, particularly in an older population who has diabetes and small vessels. And so if you have a process of care system that allows 80 out of 100 patients starting dialysis to have a catheter, there are definite advantages in an upper arm in order to get the catheter out quickly. But there are also significant disadvantages. And the disadvantages, and they're coming more into everything in life and in medicine as an up and a down. The disadvantage of the upper arm brachiocephalic after you go beyond this earlier maturation is that you have a very high incidence of cephalic arch stenosis. Again, it's where you have a curve, it's where you have hemodynamic changes, it's where you go through the clavipectoral fascia, so you may not be able to expand that much. And we also know that it's much harder to open up a cephalic arch stenosis as compared to a stenosis somewhere else. And again, from a biological standpoint, that's probably because these issues like the curve and the inability to dilate up doesn't go away when you do an angioplasty. The second problem that we're recognizing more with the upper arm fistulae is that they have high flows, which is good, but the high flows could potentially, and we're thinking more and more about this, I don't know the complete answer, that there could be a detriment of a hyperdynamic circulation. So again, for the future, and to that earlier question, I think having low flow vascular accesses for portable dialysis is really good, but the high flows can cause damage to the heart, but the high flows are also thought to play a role in the abnormal hemodynamics that make your cephalic arch stenosis worse. And there's a fair amount of data coming out now that there are ways that you can decide whether you want to just dilate a cephalic arch or whether you actually need to reduce the flow by doing a ligation or a Miller procedure. So again, so many, and this is for so I will not say the word Nisha has taught me not to use, but for all the early career students, residents, and fellows and more in the audience, it's this amazing sort of system that is a lifeline. We don't think too much about it, but it has this fascinating biology, right? It's got uremic vascular biology, it's got hemodynamics, it's got shear, it's got cannulation, it's got the patient perspective with Nancy sitting there. And so it's really, again, I would put out for everyone whose early career, thank you, Nisha, yet again. I was told not to say junior, which is, I think, very correct. But I think there are huge opportunities here, and it's clearly something that is so, so important for our patients. Absolutely.